Hello my dear friends, welcome back to my channel. Today I am going to discuss part 3 of full mouth rehabilitation. I hope you have all learned part 1 and part 2 of full mouth rehabilitation. Let's begin part 3 of FMR. In this lecture, I will discuss various methods for determining the vertical jaw relations. These are the methods for determining the vertical dimension at occlusion for completely edentulous patients. That is mechanical methods like ridge relation, that is distance from incisive papilla to the mandibular incisors, then the parallelism of the ridges, then pre-extraction records, that is profile photographs, profile silhouettes, then radiography, articulated cast, facial measurements, and then measurement from the form of dentures. Then the physiological methods are PowerPoint by Booth, using wax occlusal rims, physiological rest position, phonetics, aesthetics, swallowing threshold, tactile sensor, neuromuscular perception, patient's perception of comfort. And these are the methods to evaluate the loss of vertical dimension in dentulous patients. And these are the methods used in the full mouth rehabilitation. That is pre-treatment records, incisors height measurement, evaluation of phonetics, patient facial evaluation, assessment of the facial appearance, radiographic evaluation and neuromuscular evaluation. Okay, let's discuss what is the vertical dimension. The distance between 2 points when the occluding members are in contact according to GPT. The vertical dimension of occlusion, it is a static position and it can be maintained for an indefinite time. When the vertical dimension is established for use in construction of dentures, the jaws are in centric relation. But when the natural teeth are in maximum occlusion, then the jaws are not necessarily in centric relation. Okay, so when used in the construction of dentures, then the jaws are in centric relation. And when the natural teeth are in maximum occlusion, that is in dentate patients, their jaws are not necessarily in centric relation. So the methods are pre-extraction records, that is the profile photographs. Their profile photographs are made and they are enlarged to a life size of a patient. And the measurements of anatomic landmarks on the photographs are compared with the measurements using the same anatomic landmarks on the patient's face. And these measurements can be compared when the records are made and again when the artificial teeth are tried in. And the photographs should be made with the teeth in maximum occlusion, as this position can be maintained accurately for the photographic purposes. And coming to the profile radiographs. There are two types of radiographs. They are cephalometric profiles and the condyles in the fossa to determine the vertical jaw relations. The inaccuracies existing in either the technique or the method of comparing the measurements make these methods unreliable, and also because of the radiation risk, they cannot be considered adequate for routine clinical uses. So the cephalograms and the TMJ radiographs are used to determine the vertical jaw relation. Atwood used cephalometrics to study the rest position of the mandible and found a great variability between the different readings in a single sitting, before extraction and after extraction, with or without dentures. Coming to the articulated cast, when the patient is dentulous, the maxillary cast is related in its anatomic position on an articulator with a face-bone transfer. An intraocclusal record with the jaws in centric relation is used to mount the mandibular cast. So when the patient is dentate, then the maxillary cast is related to an anatomic position on an articulator with a face-bone transfer, and an intraocclusal record is used to mount the mandibular cast. And these mounted casts give an idea of the size and shape of the teeth and the vertical overlap relation and indicate the amount of space required between the ridges for teeth of this size. And after removal of the teeth and mounting of the edentulous cast, the interarch measurements are compared. So these are the articulated cast in dentate and edentulous patients. Coming to the facial measurements, two tattoo points are placed. One on the upper half of the face and another on the lower half of the face. And patient is instructed to close the jaws in maximum occlusion and the distance is measured. And these measurements are compared with the measurements between these points when the artificial teeth are tried in. So coming to the phonetics. It is the most important method and most common method used to determine the jaw relations. And it involves observing the movements of the oral tissues during speech and listening and analyzing it. What is closest speaking space? It is described by Dr. Aaryas Vlogs in 1951. He defined closest speaking space as the closest relationship of the occlusal surfaces and the incisal edges of the mandibular teeth to the maxillary teeth during function and rapid speech. The average value is about 0 to 10 mm. Okay. What is closest speaking space? According to GPT-9, it is defined as the space between the anterior teeth when the patient is speaking. According to Dr. Earl Pound, the space should not be more than or less than 1 to 2 mm of clearance between the incisal edges of teeth when the patient is unconsciously repeating the letter yes. So this is the closest speaking space. And here the patient was made to sit erect and close into the maximum intercuspation. When the patient is edentulous, wax aesthetic controlled rim is added to the labial region. Then a line was drawn on lower anterior teeth at the horizontal level of incisal edge of opposing upper anterior teeth. The patient was then asked to pronounce yes as in yes, and closest speaking line was drawn on lower anterior teeth. Dr. Aaryas Vlogs termed this speaking centric, which was defined as the closest relationship of the occlusal surfaces and incisal edges of the mandibular teeth to the maxillary teeth during function and rapid speech. And this was later called closest speaking level by Dr. Vlogs, and finally the closest speaking space. It should not be confused with freeway space. What is freeway space? It establishes the vertical dimension when the muscles involved are at complete rest or in physiologic tonus and the mandible is in rest position. What is closest speaking space? It measures vertical dimension when the mandible and muscles involved are in physiologic function of speech. Okay, so freeway space when the muscles are at complete rest or the mandible is in rest position, and the closest speaking space is when the muscle is involved in physiologic function of the speech. And the production of CH, S, J sounds brings the anterior teeth close together without contact. And this minimum amount of space between the upper and lower teeth in this position is called Silverman's closest speaking space. Okay. It is believed that the closest speaking space for each individual is constant throughout the life. And this belief may be sustained by all or none law of muscle physiology, which states that the muscle fiber is in maximum contraction during the stimulus of function. And it was found that the closest speaking space varied from 0 to 10 mm. Okay. So what is the phonetic method? It is based upon the assumption that there is direct connection between the interdental space, occlusal plane position and the tongue position during articulation of speech. And it is a procedure of dental physiology. And this method uses physiologic stimulation of muscle activity during the production of speech sound to measure the vertical dimension before the remaining natural teeth are lost. And this measurement must be reproduced with accuracy in complete dentures. And one or more of the 6 siblings, that is S, Z, SH, ZH, CH and J, generally cause the mandible to be in closest level to the maxilla during speech. What is the method? The patient is directed to close in centric occlusion. And centric occlusion line is drawn on a lower anterior tooth at the level of the incisal edge of the opposing upper anterior tooth. So here it is a centric occlusion line. And with the patient's teeth in maximum occlusal contact, a line is drawn on the lower anterior tooth at the exact level of the upper incisal edge. and this is the maximal closure line. What is this line represents? The position of the line when the patient says yes. Notice that here it is the when the patient says yes, the position of the line. Okay. What is the position of that line? It noted that the distance from the line to the incisal edge of the S sound is about 1 mm. Okay. A new line is drawn at the incisal edge position and that is repeated during the S sound. And this is called the closest speaking line. Observe how precisely the closest speaking line is repeatedly aligned with the upper incisal edge on S sounds. And that is the centric occlusion line, that is maximal closure line and the closest speaking line. So the patient is directed to close in centric occlusion and the centric occlusion line is drawn on the lower anterior tooth at the level of the incisal edge of opposing upper anterior tooth. Draw the closest speaking line on the same lower anterior tooth when the patient pronounces yes. The patient is asked to read rapidly to determine accurately and the closest speaking line is watched to coincide with the upper incisal edge when patient pronounces yes. Okay. Coming to aesthetics, the vertical relation of the mandible to the maxilla, it also affects aesthetics. And the tone of the facial skin normally should be the same throughout. And the contour of the lips depends on their intrinsic structures and the support behind them. What is neuromuscular perception? According to Robert Lytle, the patient's tactile sense or sense for comfort is used as a gauge for determination of the occlusal vertical dimension. Here, a central bearing device which is attached to accurately adapted record bases which permits the patient to experience different comfort levels during use of vertical relations for comparison through the neuromuscular perception. Here the proprioceptive nerve endings in these ligaments, which are a part of neuromuscular mechanism, permit the patient to experience more desirable relationship. Coming to the Niswanger's method, it is used in edentulous patients. This is the most commonly used method to establish occlusal vertical dimension, and it uses the physiologic rest position, that is vertical dimension at rest, to determine the occlusal vertical dimension. Here the Niswanger stated that mediate occlusion is equal to mediate rest minus freeway space, that is 2 to 4 mm. Okay. So the Niswanger's method, here it is the freeway space of 2 to 4 mm. Here it is the vertical dimension of occlusion. Here it is the vertical dimension at rest. So what is Niswanger's method? It is vertical dimension of occlusion is equal to vertical dimension at rest minus freeway space of 2 to 4 mm. And this is the closest speaking space. Position of the anterior teeth govern the vertical separation between them during pronunciation of CH, S, J. Incorrect positioning will result in obliteration or opening of this space. That is closest speaking space, which will result in the altered pronunciation of these words. Coming to bimeter method, that is PowerPoint method by Booth, in 1940 demonstrated that the maximum biting force in an individual is registered at vertical dimension at rest. Here it attaching a pressure indicating gauge which displayed the biting pressure to a central bearing plate. Here it is the central bearing device. So central bearing plate and screw on the occlusal rims. And the device is called the bimeter and the maximum biting point is termed as power point. So the maximum biting point is known as the power point. Hence it is known as PowerPoint method by Booth. The screw is adjusted to increase or decrease the vertical dimension and the bite force is recorded with each insertion. So bimeter is used to determine the bite force and thereby the vertical dimension. Booth stated that the vertical dimension of occlusion is the rest position or maximum force minus 2 mm. And this picture shows some such sectional cast. Here it is a sectional cast, a posterior view of sectional cast. When the teeth are in centric occlusion, the incisal edges of the mandibular central incisors are on average 4 mm. Okay, here it is the 4 mm from the incisive papilla. This is the incisive papilla. And here it is the 4 mm. That is the incisal edge of the mandibular central incisors. Here the sagittal view of the central incisor. And in this picture, it shows the vertical overlap, which is variable and often ranges between 0.5 to about 2 mm. And this overlap is selected on the basis of aesthetic and functional occlusal contact determinants. Here, this picture shows the increasing vertical dimension of occlusion is a problem. Some delta stage bruxes which having severe attritional wear that requires the restoration. How the condyle position affects vertical dimension? How the condyle position affects vertical dimension? Because of the elevator muscles, the repetitive contracted length of the elevator muscles that determines the repetitive end point of the closure of the mandible. And in turn, it determines the point at which erupting teeth contact and the point at which the eruptive forces are neutralized. So in this picture, if there are no deflective occlusal interferences which require downward displacement of the TMJ from centric relation to achieve maximum intercuspation, the vertical dimension at A, here it is the vertical dimension at A will stay constant. If you increase the vertical dimension, it will always revert back to this dimension as the anterior teeth, as the muscles close the bite back to where it was. Here it is the elevator muscle. So the repetitive contracted length of the elevator muscle which determines the repetitive end point of the closure of the mandible. And this picture shows if the vertical dimension of the anterior face, here the vertical dimension of the anterior face is achieved by downward, forward displacement of the condyles from the centric relation, and at this jaw relationship, that the muscle length, here it is the muscle length which establishes the vertical dimension of occlusion, not the upward movement at the front of the mandible as the condyles move down. The pivot point is usually at the most distal tooth. So most distal tooth, here it is the pivot point. Okay, here it is the upward movement of the front of the mandible as the condyle moves down. And in this picture shows condyles are seated up into the centric relation. Okay, here the condyles are seated up into the centric relation. The vertical dimension at the front is increased. Because the condyles move upward, the muscle length at B is shortened. Here the muscle length which is shortened because of the condyles move upward. And this permits an increase in the vertical dimension. Here it is the increase in the vertical dimension which occur without lengthening the muscles at B. Such an increase at the front could be stable because it does not interfere with the repetitive muscle contraction length. Hence the condyle position which affects the vertical dimension. Okay. When there are no opposing teeth, establishing the vertical dimension of occlusion. How? Here it is the centric occlusion line as we already discussed. Here with the patient's teeth in maximum occlusal contact, a line is drawn on the lower anterior tooth at the exact level of the upper incisal edge. And this is known as maximal closure line. And this picture shows the position of the line when the patient says yes. Notice that the distance from the line to the incisal edge of the yes sound is about 1 mm. And the new line is drawn at the incisal edge position that is repeated during the S sound. And this is called a closer speaking line. Observe how precisely the closer speaking line is repeatedly aligned with the upper incisal edge on S sounds. How to measure vertical displacement of the condyles? Using the determinant index on the Dinar-Combe articulator. This is the determinant index on the Dinar-Combe articulator. It can be used to determine the vertical displacement of each condyle during maximal intercuspation. So this is the determinate index on the Dinar-Combe articulator. It is used to determine the vertical displacement of each condyle during the maximal intercuspation. Here is the determinant index. Here the casts are mounted in centric relation with the condylar path insert in place. Okay, so here the casts are positioned from centric relation into the maximum intercuspation. The condyle displacement can be observed through clear plastic. Okay, here it is the condyle displacement can be observed. Then here the distance between the top of the condyle and the roof of the fossa can easily be seen and measured. Distance between the top of the condyle and the roof of the fossa. Okay. So remove the condylar path insert and replace it with the determinant index. The condyle ball should be against the back wall and the roof of the index. Then position the cast into the maximum intercuspation and measure the space between the top of the condyle and the roof of the index. How to determine the vertical displacement using a sentry check recording, that is Teledyne Dinar-Combe articulator. This is the Dinar-Combe articulator and this is a sentry check recording to determine the vertical displacement. Record the needle point indentation with the cast seated in the centric relation. Bite record. Here it is the cast which is seated in a centric relation bite record. Record the needle point indentation. Okay. Then remove the bite record and seat the cast into the maximum intercuspation. Record another needle point indentation at the maximum intercuspal position and measure the vertical displacement from the centric relation indentation to the MIP indentation. What are the other methods? The condylar position indicators are available for several semi-adjustable articulators. Here SAM articulator with condylar position indicator, and the process is the same but record the position of the condyles at the centric relation. Remove the centric relation bite record and record the condylar position at the maximum intercuspation. Then simply measure the vertical displacement from the centric relation position to the MIP position. Okay, so there are several condylar position indicators are available for various types of semi-adjustable articulators like SAM articulator. Okay, here is the condylar position indicators. If the determinations are being made on a patient who has already lost the natural vertical dimension of occlusion, the missing teeth can be substituted for temporary restorations or on fabricated pieces. After proper lip support, aesthetics and incisal edge position have been determined, the phonetic method can be used to establish the vertical dimension. See these figures. What is this figure depicts? Here is the wax aesthetic controlled rim is adapted to the denture base and contoured to relate to the smile line, and the wax is then adjusted to contact the inner vermilion border of the lower lip when an F sound is made at soft speaking level, and this will be used later to establish the incisal edge positions for the teeth on the denture. Here another wax aesthetic rim is attached to the lower denture base to conform to where the lower incisors will be placed. Okay, here the another wax aesthetic rim is attached to the lower denture base to conform to where the lower incisors will be placed, and the wax can be contoured or bent until an S sound can be made comfortably. Here it is the S sound. So wax can be contoured or bent until an S sound can be made comfortably. Okay, and by noting which line on the lower rim aligns with the upper incisal edge, the closest speaking position can be determined. And central relation bite record is then made at a closure of 1 mm past the speaking alignment. And what does this picture represents? The denture teeth are then set up. Okay, here the denture teeth are then set up, so their incisal edges and labial surfaces are exactly in line. with the aesthetic control banks. Okay, so here the denture teeth are set up. So their incisal edges and the labial surfaces are exactly in line with the here the wax aesthetic control wax cells. Okay. According to Harry's teacher, when bone and muscle war, muscle never loses. According to Peter A. Dawson, when the teeth and muscle war, muscle never loses. And summarizing the various methods to evaluate the loss of vertical dimension, pre-treatment record, that is evaluation of previous diagnostic models and photographs. What are the advantages? It is a rough estimate of vertical dimension and it also doubles up as a baseline record. And the disadvantages are old diagnostic models are extremely difficult to solve. Then incisors height measurement. It refers to the distance between the gingival margin of maxillary and mandibular anterior teeth when they are in occlusion. When it is less than 18 mm, it indicates the loss of vertical dimension. Okay, so what is incisor height measurement? It refers to the distance between the gingival margins of maxillary and mandibular anterior teeth when they are in occlusion. And when it is less than 18 mm, it indicates the loss of vertical dimension. Advantages is that it gives us an approximate loss of clinical crown height. It measures the severity of tooth wear. And the disadvantage is poor accuracy in determining the loss of vertical dimension. Then evaluation of phonetics. The letter S, it measures the closest speaking space. Letter F determines the incisal edges of worn out maxillary teeth. Letter M locates the mandible in a relaxed retrograde position. And this technique is clinically reproducible and it determines the relationship of the incisal edges of the maxillary teeth to the lower lip. This technique is more relevant during complete denture fabrication. Cannot be used in patients with class 2 and class 3 occlusion. Then patient facial evaluation. Evaluation of the resting position of the mandible, facial tissues and the muscles at rest. It can be applied clinically and this technique visualizes the facial appearance at rest. Any change in the muscle tension will cause errors in the measurements and it is an arbitrary technique. Assessment of facial appearance. Evaluation of facial tissues and musculature at rest. It can be applied clinically and this is an arbitrary technique. Then radiographic evaluation uses a cephalogram to assess maxillomandibular relationship. It is highly accurate and it is reproducible. Then the radiograph provides information regarding the incisor relationship as well. And the disadvantage is that exposure to radiation. Then finally, the neuromuscular evaluation. This technique uses an electromyography machine to record the muscle activity. Minimal muscle activity indicates that mandible is in rest position. And this is the gold standard in determining the vertical dimensions. Very important question in Viva. That is, which one is the gold standard in determining the vertical dimension? That is neuromuscular evaluation. It will be discussed separately in next coming sections. And it is most accurate, reproducible, primarily used in universities for research. Not commonly used in a clinical setup. Controlled environment is necessary to get accurate measurements and it is technique sensitive. That is all about the methods for determining the vertical jaw relations. Thanks for watching and please do subscribe, like and share my videos for more updates.